and welcome back to the channel. I hope that everybody is doing well today. If you are new here, then hi, my name is Brittany and I'm a nurse practitioner, and I am also the creator of the Brittany Holzbeck NP review. It is currently the most affordable and comprehensive NP review on the market, and I was just given accreditation through the AANP, so now nurses and nurse practitioners alike can actually take the course to collect continuing education credits. If you are interested in signing up for my course, I will have everything linked in the description box below. Also, I do have another channel here on YouTube. It's more like lifestyles, motherhood, vlogs, stuff like that. So if it is something that you're interested in, you want to come check me out, I will also have that linked in the description box below. Otherwise, for today's video, I am going to be talking all about dyslipidemia, how we diagnose it, how we treat it. Definitely a hot topic for your board's exam, and definitely something you will see quite frequently in practice. But before I get into it, if you can do me a big favor and go ahead and like the video and subscribe to the channel, it is a free way to help me out and I really do appreciate it. But otherwise, let's just get into the topic of how to manage dyslipidemia. Alright, so first let's talk about what dyslipidemia is. So dyslipidemia is defined as an abnormally elevated cholesterol or lipids in the blood, and this increases the likelihood of clogged arteries, which is a known risk factor for atherosclerotic cardiovascular disease. So on the screen here is a lipid panel. These are the normal values that you would see, along with the borderline and abnormal values. Remember, if you're taking the AANP exam, you do not need to have labs memorized. Those are provided for you on the exam. But if you are taking the ANCC exam, you do need to know your lab values. And so I would just recommend, regardless, that you review these and you become familiar with these lab values. So the blood contains three main types of lipids. This includes high-density lipoproteins, or HDL, low-density lipoproteins, or LDLs, and then the triglycerides. So LDL cholesterol, this is considered the bad type of cholesterol, and this is because it can build up and form plaques within the arteries. And then the HDL, this is considered the good cholesterol, and this is because it helps to remove LDL from the blood. And then finally, there are the triglycerides, and this is another type of lipid that's found within the blood. These are actually stored within fat cells, and they are used for energy. And the way that I remember the difference between HDL and LDL is, think L for lousy and H for happy, or H for healthy, whatever sticks in your brain better. But that's how I kept those two differentiated. So all patients with an elevated LDL, they should be counseled on the benefits of exercise and a healthy diet as a mainstay of treatment and prevention for cardiovascular disease. And so we're going to go over some more treatments here in these next few slides. But that is always going to be mainstay. Alright, so next up, let's talk about screening recommendations. So there are a variety of recommendations regarding when to screen patients for dyslipidemia. I'm going to cover what the AHA, or American Heart Association, and both UpToDate recommend, because these two generally mirror the same guidelines. So when reviewing UpToDate, they acknowledge that there are discrepancies amongst the guidelines. However, the authors do recommend following the AHA recommendation. So for children that have one or more risk factors for early cardiac disease, they recommend screening for dyslipidemia at the first notice of these symptoms, but no earlier than 2 years. And so it's good to know what risk factors would be for early cardiac disease, examples of those, aside from obviously dyslipidemia. So other examples would be obesity, diabetes, hypertension, a family history of early cardiac disease, exposure to smoke, chronic kidney disease, familial hypercholesterolemia, Kawasaki disease, childhood cancer, congenital heart defects, cardiomyopathy, HIV, and then finally adolescent depression and bipolar disorders. Those are also going to be risk factors for early cardiac disease. And then children that do not have risk factors for early cardiac disease, they're recommending that screening for dyslipidemia occurs twice during childhood. It should occur once between the ages of 9 and 11, and then again between the ages of 17 and 21 years of age. Screening, it's noted that it should not be done between the ages of 12 and 16, and this is because we know that lipid changes can occur due to puberty, and it would make the testing less accurate. These early age recommendations are done because we know that there are dangerous side effects of chronic exposure to high cholesterol levels. And so, of course, we want to catch this hypercholesterolemia as soon as possible. UpToDate also states that if a young adult is being evaluated and they were not screened for hypercholesterolemia in their childhood, like we just discussed, then they recommend getting a lipid profile baseline at that first visit and then using the CVD risk calculator to further guide screening recommendations going forward. And we're going to actually discuss that ASCVD calculator, or the atherosclerotic cardiovascular disease calculator, on this next slide now. All right, so let's talk about the ASCVD calculator and how it helps us tailor our patient's treatment plan. So as I mentioned, statin therapy, we know that this is the first-line treatment for dyslipidemia. And statins work by slowing down the liver's production of cholesterol, improving the liver's ability to remove cholesterol from the blood, and it's shown to help both reduce the risk of myocardial infarction and ischemic stroke. And so that's huge. This drug class reduces a person's relative risk for cardiovascular disease by about 30%. However, when we're considering absolute risk, the use of statin therapy is beneficial in proportion to the severity of the individual's underlying cardiovascular disease. And this means that individuals with a lower baseline risk for cardiac disease have a lower absolute benefit with statin use. Compared to those that have a higher baseline risk for cardiac disease, these persons will have a higher absolute benefit from using statins. So how are we to determine which patients would benefit most from statin therapy? So in addition to collecting that lipid panel, which we talked about, we also calculate our patient's risk for a cardiac event in the next 10 years, and that's using that ASCVD calculator. So ASCVD risk evaluations and discussions should begin at 20 years of age or at the first encounter with the healthcare system, whichever occurs first. So repeat screenings is then based on that person's calculated risk using that ASCVD calculator. So patients that have a 7.4% risk or less for a cardiac event occurring in the next 10 years, and if there are, of course, no changes to that person's health, like they had a heart attack, then repeat screening would be recommended every 4 to 6 years. And then patients that have an intermediate risk, so that's 7.5 to 19.9% ASCVD risk, the literature recommends that we screen them more frequently than every 4 to 6 years, but the optimal time interval for reassessing is uncertain. They actually do not define that, and so we will have to use, of course, our clinical reasoning and base that per patient. So for looking up the ASCVD calculator, you can look it up online. You can just type it in Google and you will pop it up, and you can input your patient's information using that calculator. It asks things like the person's age, their blood pressure, their cholesterol, their smoking history, and whether or not they have diabetes. And then you input all of the data. It calculates your patient's risk of having that cardiac event in the next 10 years. And then depending on the results, we then tailor our treatment plan and statin use for that specific patient. So a low risk for a cardiac event occurring in the next 10 years is considered a result that's less than 5%. An intermediate risk is 5 to 10%. A high risk is greater than 10%, and then a very high risk is 20% or greater. And so here on the slide, you see the different indications for statin therapy. One, if a person has an LDL that's 190 or greater, generally a CVD risk calculation is unnecessary because this high of an LDL is indication for statin alone. So you would not need to have that result from the ASCVD calculator to have a good reason to initiate a statin for that patient. The second one here is if the patient has an LDL of 190 or less. The indication for statin therapy is then dependent on their individual risk for the cardiac event in the next 10 years using that ASCVD calculator. So if they have an intermediate risk, which remember that's 5 to 10% risk of cardiac event within the next 10 years, and an LDL that's less than 190, in these circumstances, there should be a shared decision making between the patient and the provider, and of course that's weighing both the pros and cons of starting a statin. Risk factors that would generally indicate that you should go on the side of initiating the statin would be if they have an LDL that's greater still than 160, if they have a family history of premature cardiac disease, so in males that'd be less than 55 years, and in females that'd be less than 65 years, if they have metabolic syndrome, chronic kidney disease, chronic inflammatory conditions, if they have history of premature menopause, so that would be earlier than 40 years, or if they have history of pregnancy-associated conditions that are associated with cardiac risks, such as preeclampsia, and finally, if they belong to a high-risk ethnic group, such as South Asian ancestry. And then if they have a high risk for cardiac disease, so this is defined as greater than 10% risk for cardiac event in the next 10 years with an LDL greater than 100, then statins are definitely indicated for this population. A high risk for cardiovascular disease would be an indication for a moderate intensity statin. So examples of a moderate intensity statin would be a 10 or to 20 milligram atorvastatin or a 5 to 10 milligram of rosuvastatin. It's recommended that with these patients, we measure their LDL response at 6 weeks after starting them on their statin, and then every 12 months thereafter to make sure that they're staying compliant, that the dose is still effective, and that the patient's overall health status is still doing well. And then finally, a very high risk for cardiac disease is an LDL between 100 to less than 190 with a 20% risk or greater for a cardiac event in the next 10 years. And in these circumstances, a moderate intensity statin is still the recommended statin, though the literature does say that we could also consider a high intensity statin. But again, it's always going to be weighing those pros and cons with the patient. Alright, well that is going to complete today's video. Hopefully you learned a little something. If you are interested in seeing the complete video, then definitely go ahead and check out my Patreon. Again, that will be linked in the description box below. Otherwise, I hope you enjoyed today's free video. Hopefully it's helping you in your studies or in your practice. Don't forget, if you have any questions or comments, go ahead and leave them in the comments down below. Also, don't forget to like the video and subscribe to the channel. I really do appreciate it. Otherwise, I wish you guys nothing but the best. Don't forget to learn something new every day, and I will talk to you soon.